Good afternoon, everyone, and thank you very much for joining this nice webinar, which is all about our new obesity reference case extension. Um, Before I go and introduce our agenda and speakers, I just want to notify people that we are recording this webinar. Um, and you can submit questions that you might have for NICE and any of the speakers and any of the content that we are talking about today, that you can submit via the Zoom Q&A function that should be available at the bottom of your screen. We have a number of presenters who will all present their different sections of the agenda, and then there are questions at the end that we will then cover. But please do not wait until the end. If you have questions throughout, submit them through the Q&A, and we'll try and go answer as many as we will have time for. The total time we have for this webinar is 1 hour. So I probably should introduce myself. I'm Jacoline Bouvy. I am the Program Director for Medicines Evaluation at NICE. And today we have a number of different speakers from NICE. So Lindsay Claxton is a health economics advisor who is going to sort of set the scene and talk about sort of the background to how NICE came about developing a reference case extension for obesity. Dave Wonderling, who's a senior health economics advisor, will then describe and take you through the reference case extension in more detail. And then Sophia Kemmis-Betty, who is a health economics advisor at NICE, will talk about the implementation as part of NICE's ways of working of the reference case extension. And then, as I mentioned, at the end, we have time for questions. So I think that is everything that I have to say before handing over to Lindsay, who's going to take you through the first part of the agenda. Over to you.
Great, thank you, Jack. Hi, everyone. Good to see you all here on this sunny day. So I'm Lindsay. I'll be taking you through a bit of a background as to how NICE routinely considers cost-effectiveness evidence, and then how we got on to developing our obesity reference case extension. So NICE considers the cost-effectiveness of health technologies when making our guidance. And one of the reasons for doing this is that the NHS does not have enough resources to do everything. And so we consider the balance between the benefits and costs of different health services. This helps the NHS use its limited budget to maximise health outcomes for the whole population, and we can prioritise those interventions that have a high health gain per pound spent. So how do we decide if an intervention is cost effective? So economic evaluation is a comparative analysis of alternative courses of action in both of their terms of their costs and their consequences. So as part of this, we estimate the total additional costs and the total additional outcomes of one course of action compared to another. And the ratio of these represents the cost per additional outcome, or the incremental cost effectiveness ratio, which we usually refer to as the ICER. Then we can then compare the ICER to a cost effectiveness threshold to indicate whether it's cost effective or not. So, for example, we might have medicine A, which costs £500, and medicine B that costs £800. But medicine B might have fewer rehospitalizations over time and fewer adverse events. So even though it's more expensive up front, medicine B might be a good use of NHS funds as it improves health and reduces downstream costs. So our preferred measure of health outcome at NICE is the Quality Adjusted Life Year, or the QALY. A QALY combines both life expectancy and health-related quality of life into a single index. We measure quality of life as utility values on a scale of 0 to 1, where death is equivalent to a score of 0 and full health is equivalent to a score of 1. Using QALYs, allows comparisons to be made within and across different types of conditions. It is not easy to compare, say, 2 cases of breast cancer against 20 cases of diabetes. However, it is more practical to compare QALYs against QALYs. So NICE guidance is typically underpinned by an economic model which estimates the cost effectiveness of different interventions. So economic models are mathematical frameworks which allow us to estimate the ISA, or the cost per QALY gained, to help inform whether an intervention is cost effective. They can predict outcomes over a longer time period that might be captured in clinical trials, or they can link intermediate to final endpoints. They could also be used to explore the limitations of sources of data and explore uncertainty in a formal and structured way. When we develop an economic model, we bring together data from a variety of sources, such as treatment effects, unit costs and resource use, and patient preferences for health states. The model framework then combines this data and estimates the total costs and QALYs over a specified time horizon for each intervention, and this allows us to estimate the ISA. So NICE makes decisions across different technologies and disease areas. So it's crucial that analyses done to inform the economic evaluations are consistent with each other. So to allow this, NICE has defined a reference case that specifies the methods for health technology assessment that we consider to be appropriate for our purposes. The NICE reference case includes statements on a number of different elements, such as comparators, the perspective of outcomes and costs, the type of economic evaluation, the time horizon, and on discounting. And it also sets out the approach to measuring and valuing health effects and resource use and costs. However, variation between economics continues to exist, even within a condition. And this variation can cause inconsistency between different pieces of NICE guidance, especially as the underpinning analyses are often not regularly updated. So now I'm going to talk about reference case extensions. So NICE is now producing guidance by taking a whole life cycle approach. This means that we produce NICE guidance in a way that recommendations for all technologies can be seamlessly incorporated into relevant guidelines when they are published. This will allow the NHS to stay up to date by constantly reviewing what works best, how care can be improved, and where treatment should evolve over time. So last year, we published our position statement that set out our intention on developing reference case extensions in selected disease areas. So the position statement was developed to support this whole life cycle approach to guidance development by enabling standardised health economics modelling approaches. As part of this process, we reviewed the academic literature to understand the benefits of challenges in using reference models in HTA. And we also surveyed international HTA bodies and received feedback from colleagues across NICE on their experience with reusable economic models. So disease-specific reference case extensions are, as the name suggests, extensions to the NICE reference case, and they specify the characteristics an economic model should have for a specific condition. They set out agreed standards for how treatment should be modelled to encourage consistency and accuracy in future guidance, and any deviations need to be explained and justified. They apply across NICE directorates, including medicines, evaluation, health tech, and clinical guidelines, and so they can help to bring guidance together. Reference case extensions can include statements on patient demographics and populations, treatment comparators, the model structure, and key model assumptions. They will specify data sources, and in some cases, they might specify some input values. They are evidence-based and developed with extensive stakeholder engagement throughout. Barriers to implementing these within NICE processes are lower than with reference models, but they can be considered an intermediate step to implementing reference models, since conceptualization is the first step in developing a health economic model. So management of overweight and obesity in adults was selected as the topic of our first reference case extension. The first reason was due to its public health significance. Obesity is strongly associated with ill health, and it impacts a large proportion of the population. Secondly, obesity is a complex area to model. It is associated with exacerbation of many other chronic conditions, and health benefits of obesity interventions are often driven not simply by weight loss itself, but by reducing the risks of weight-related comorbidities. Interventions for obesity span everything from diet and exercise to psychological support, bariatric surgery, and now a new generation of pharmaceutical treatments and minimally invasive surgery. Many of these emerging medicines and technologies are evaluated by NICE offer the potential for substantial health gains, but they come with significant cost implications for the NHS. An obesity reference case extension represents an opportunity to establish modelling good practice in an area where economic models are still emerging, and to ensure that the NHS uses its resources in the best possible way. This reference case extension also aims to address the inconsistencies in existing approaches to economic evaluations in obesity across NICE guidance programmes, both in which comorbidities are included and how they're modelled. Addressing these inconsistencies in future obesity guidance will help us bring it all together as part of the whole life cycle approach. Development of this piece of work was led by the Health Economics and Decision Modelling team and involved a cross-NICE collaboration, including Centre for Guidelines, Health Tech, Medicines Evaluation, the Clinical Directorate, and Healthcare Data Analytics. First of all, we conducted a review of existing economic evaluations in obesity, focusing on existing NICE guidance. This allowed us to identify and understand key challenges associated with the evaluation of obesity-related treatments. So during development, we then conducted a series of workshops involving clinician and patient advocates, health economists, industry representatives, and NHS commissioners. After the draft reference case extension was developed, it underwent consultation, where we received feedback from a wide range of stakeholders. These included patient and professional bodies, ICBs, prescribing organisations, pharmaceutical and medical device companies, NHS England, ABPI, and academic institutions. The reference case extension was then updated and finalised, and responses to stakeholder feedback were published alongside the guidance last month. Overall, we received positive feedback during consultation about having a reference case extension in the area of obesity. 2 stakeholders did propose making it a guide though rather than mandatory. We received many comments on the specific elements of a reference case extension itself, demonstrating diverse opinions from different stakeholders. So following consultation, we updated the draft reference case extension in response to feedback and published individual responses to stakeholders. So changes made to the reference case extension included greater emphasis on directly measured outcomes and using risk equations when high quality direct outcomes do not exist. The principles for including outcomes were given greater prominence within the reference case itself, and we included more detail on outcome definitions, such as for atherosclerotic cardiovascular disease. We also added a section on recommendations for further data analysis to support the development of model inputs. So that's all about the process and how we selected our first topic. So now I'm going to hand over to my colleague Dave, who's going to speak to you about the content of a reference case extension itself.
Okay, thank you very much, Lindsay, and hello, everybody. So what we'll do over the next few slides is walk through some of the key elements of the reference case extension, starting with population, then comparators and model structure, before moving into outcomes, treatment effects, valuation of benefits, and finally, equality considerations. The aim here is not to cover every line of the document, but to highlight the core principles and rationale. And before we start, note that I've pruned some of the statements for conciseness of presentation. For implementation purposes, please refer to the full wording in the reference case extension document itself. Next slide, please. So, starting with the population, one of the key principles is to explicitly reflect heterogeneity in outcomes. The reference case extension specifies that results should be stratified by key clinical characteristics, in particular, the presence or absence of type 2 diabetes, the presence or absence of atherosclerotic cardiovascular disease, and whether people are overweight or living with obesity. The rationale here is quite important. By structuring analyses in this way, we can isolate the benefit of the treatment for obesity from its benefits for treating cardiovascular disease and diabetes. We enable the NHS to identify where treatments provide the most benefit and most value for money, and we support alignment within existing NICE guidelines. In addition, baseline characteristics such as age, sex, and weight should be estimated using real-world evidence representative of the NHS population in England. This helps ensure the analysis is relevant to the people actually treated within the NHS. Next slide, please. Moving on to comparators, the principle here is straightforward. Models should compare new interventions against relevant alternatives that are already used in the NHS. This includes behavioral interventions, medicines, digital technologies, and bariatric procedures. However, we appreciate that including every single possible intervention is a big ask. Therefore, we ask that at a minimum, new medicines should be compared with those already established in practice, and new bariatric procedures should be compared with existing bariatric procedures. Likewise, new digital technologies should be compared with existing digital technologies. The rationale is to ensure that decision-making reflects real choices faced by the NHS rather than hypothetical comparisons. This is especially important in obesity, where there is broad and evolving treatment landscape, and ensuring the right comparators are included is key to producing meaningful cost-effectiveness results. Next slide, please. So, turning to model structure, the preferred approach is a state transition model, either as a cohort model or in an individual patient simulation. These approaches are recommended because they can capture multiple outcomes over time, are widely understood across the HTA community, and are well suited to chronic conditions like obesity. That said, the reference case extension does not mandate a single modeling approach. Alternative methods can be used, but they must be transparent, well validated, and capable of capturing all important differences in costs and outcomes. So the message here is that transparency and fitness for purpose are more important than strict uniformity. Next, the reference case extension sets expectations around health outcomes included in the model. Health state should capture key dimensions of disease, including diabetes status, cardiovascular status, presence of chronic kidney disease, and weight group. In addition, models should include important cost-generating health events, such as joint replacement surgery, bariatric surgery, or bariatric procedures, I should say, and treatment-related adverse events. The outcomes chosen are health states or model events have been prioritized because they have strong evidence linking them to weight and weight loss. They have a significant impact on costs and QALYs, and they are important to both patients and clinicians. They are also commonly used in existing models and reflected in core outcome sets, which supports consistency across analyses. So On treatment effects, the key principle is to use the most robust and relevant evidence available. Where possible, models should use directly measured outcomes, for example, observed effects on cardiovascular events or on the incidence of type 2 diabetes. This is because they are typically the least biased estimates, and to estimate the absolute effects for those outcomes, relative treatment effects from trials should be combined with baseline event rates. And importantly, those baseline risks, baseline event rates should be derived from real world NHS data and be specific to the population stratum and the health states being modeled. The rationale is that while trials provide strong internal validity, real world data often better reflects the NHS population, improving the relevance of the model results. Yep. Next slide. Yes, thank you. Turning to how we value health benefits, the reference case extension reinforces the use of the EQ5D utility values, consistent with the general NICE reference case. However, it goes further by recommending that these utilities should vary by age, sex, and body mass index group, and should be adjusted over the time horizon of the model as these characteristics change. In addition, utility decrements should be applied for specific comorbidities and events. Ideally, these estimates should come from a single data source that jointly captures weight, comorbidities, and demographic factors. The main rationale is to avoid double counting and to ensure models capture both the quality of life impact of known conditions and the broader impact of weight that may not be directly captured through specific comorbidities. Finally, the reference case extension highlights equality and wider considerations, which are particularly important in obesity. So where distributional cost effectiveness analysis is undertaken, and that's where we subdivide economic analysis results by different socio-economic groups, and this in accord with the NICE manual should consider variation across deprivation groups. Anyway, where this distributional cost effectiveness analysis is undertaken, it's required that variation in disease prevalence, treatment uptake, and adherence should all reflect the deprivation group. This reflects that the evidence that obesity and its outcomes are unevenly distributed across the population. In addition, the reference case extension encourages qualitative consideration of impacts that won't be fully captured in the model, such as health inequalities related to protected characteristics, access to other treatments, and outcomes like fertility. The key message here is that not every outcome can be modeled, but it's still for committees to decide how much these emissions matter to decision making. Okay, thank you for listening to me. And now over to Sophia, Kemmis-Betty.
Thank you, Dave. Good afternoon, all. I'm going to talk you through how the obesity reference case extension will be implemented in practice and what this means for those developing evidence for NICE. I'll cover how it will be used, how we're supporting implementation, and briefly the data work we're doing to underpin it. The reference case extension applies to NICE topics scoped from May 2026 onwards. It covers economic evaluations of interventions for overweight and obesity in adults, and is primarily intended for cost-utility analyses. Treatments that have multiple indications, including for obesity, are covered. Importantly, it applies across NICE programs, so medicines evaluation, health tech, and guidelines. The reference case extension provides standardized methods, but not a single model structure. Here we are aiming for consistency, not uniformity. In the reference case extension, we distinguish between required and recommended statements. This is one of the most important concepts. Required statements reflect established best practice and are expected to be followed in most analyses, and any deviations will need strong justification. For recommended statements, these are still important, but more flexibility is allowed depending on the decision problem. We are aiming for transparency, not restriction. You can deviate, but you will need to explain why. In practice, the reference case extension should be considered early at the scoping stage. It should be tailored to the specific decision problem, so not every element will apply in every case. Where deviations are needed, these should be identified early and agreed with the committees and through NICE's quality assurance processes. This approach helps to avoid issues arising later in the appraisal or development process. So I'm going to take you through an overview of the implementation support that we will be providing. Internally, we are embedding the reference case extension into our NICE processes, and that includes updates to our scoping templates and our quality assurance processes. We are also developing practical tools, such as checklists, to support consistent application. Importantly, we're undertaking data analysis to help strengthen the evidence base used in modelling. We plan to monitor use in practice and capture learning. Externally, we're supporting implementation through a range of activities, and that will include webinars like this one, publications, and conference presentations. We're also encouraging early engagement through NICE advice. The aim is for early alignment so that modelling approaches are consistent with the reference case extension from the outset. The reference case extension is not intended to be static. We will monitor how it is used in practice, including uptake and adherence. We'll look at where deviations occur and why. And we will update the obesity reference case extension over time as and when new evidence and methods emerge. So now I wanted to talk you through a key part of the implementation, which is strengthening the evidence underpinning our economic models. The reference case extension places emphasis on areas such as population heterogeneity, comorbidities, and long-term outcomes. In practice, these are areas where evidence has often been inconsistent across models. So we are using real-world data to help address this, specifically CPRD data linked to hospital admissions and mortality data. In our data analysis, we stratify the population by key characteristics. This allows us to estimate clinical risk factors and event rates. These estimates can then be used as inputs in economic models. This work helps translate the principles in the reference case extension into practical, consistent model inputs. We aim to have this available on the NICE website this summer. We will, of course, inform stakeholders when this has been done. And I'll go in a little bit more detail into this analysis. We will be classifying adults into 16 groups based on body mass index, type 2 diabetes, and atherosclerotic cardiovascular disease, allowing us to compare risk across clinically meaningful subgroups. The first set of analyses focus on understanding the population itself. We estimate how common each subgroup is and how these groups differ by age and sex. Next, we describe baseline clinical risk factors such as blood pressure, blood sugar levels, cholesterol, and kidney function. These provide a snapshot of underlying health risk across groups. We then look at what happens over time, specifically over 1 year. This includes all-cause mortality and the incidence of important health events. These events range from cardiometabolic conditions like type 2 diabetes and heart failure to cardiovascular events such as heart attack and stroke, as well as surgeries, procedures, and certain cancers. There are a few important strengths to highlight. First, the use of linked data means we capture outcomes more completely than using general practice data alone. Secondly, we account for differences in risk across ethnic groups by using ethnicity-adjusted BMI thresholds, and we test this through sensitivity analyses. And thirdly, all results are generated consistently across the same set of patient groups, making them directly comparable and suitable for modeling. So these analyses will give us a strong data-driven foundation for informing models and ultimately support better decision-making. We do have some further reading recommendations for you, and that includes the obesity reference case extension itself, which is PMG 50, and you can also have a look at the NICE methods manuals. These links will be shared with you after the webinar. We'll also continue to provide supporting materials as implementation develops. Thank you very much. I'll hand over back to Jack now, who will chair the Q&A.
Great. Thanks very much. I think there are a couple of questions coming in. So the first question, Dave, I have is for you. And the specific question is whether all subgroups that you outlined and that are specified in the reference case extension are required.
Thanks, Jack. So, I mean, the first thing is that what we've identified as the strata, which are defined by presence of cardiovascular disease, presence of type 2 diabetes, and whether whether the population is living with obesity or living with overweight. It's important that all those strata are modeled separately. However, there could be a piece of guidance, be it a TA or health tech evaluation, that is focused in only one of those strata. That's fine. If the indication for the treatment is only within one, then you only have to model one. But if it overlaps, then we do expect it to be stratified accordingly. In terms of the other subgroups, I think we appreciate that fine tuning might be problematic in terms of the data. So we're not we don't think they should be applied so strictly. However, you know, they do provide important sources of heterogeneity. And if the NHS is to focus on those patients that will benefit the most in a cost-effective way, then it's really valuable to do those analyses. So you will have to justify not doing them. But there is a bit of a get out in as much as if there's no heterogeneity of treatment effect in terms of the relative effect, then you might be able to apply that across different strata and different subgroups. And whereas it's with the baseline risk that we think it's important that they are differentiated by group. And we are doing some data analysis at the moment, which we're going to publish on the website quite soon, which will provide some useful baseline event rates for a model.
Great,
I hope
thanks.
that helps.
Yes, that was very comprehensive. Thanks, Dave. Sophia, the next question I'm going to ask you, will this be extended into the development of a disease-specific reference model for obesity in the future?
Thank you, Jack. We haven't made a decision on that yet, but which is the short answer. But if you do think it's a good idea, we suggest that you reach out to NICE and we will take feedback from the wider stakeholder community. Thank you.
Thanks very much. Lindsay, the next question is for you. Will NICE develop reference case extensions for other disease areas, and how are these prioritized?
Yeah, so we are actually working on another one at the moment for MASH, which is an acronym that I can't think of off the top of my head, I'm afraid. Dave is working on this, so he'll be able to spell out the full acronym after I finished speaking. Yeah, so other topics, we haven't identified them yet, but what we're doing at the moment is we're developing a selection framework, and we're working on this at the moment. And then at some point, we'll make it into a process guide, so it'll be publicly available for people to view. So this will be based on identifying topics which are clinical priorities, where we can make the greatest impact on patient outcomes and on NHS budgets. And also it will take into account other factors as well. So things related to health economics and modelling approaches. So it's where a unified approach can most add value to our guidance. So this might be where there's an absence of relevant high quality and usable health economic models, or where there's significant methodological weaknesses or inconsistencies in modelling approaches in existing models. So we'll also consider where modelling methods are not yet well established, such as when there are technologies in the pipeline. So this is an area, this is one of the main criteria, excuse me, that drove the selection of MASH, because we are only starting to see now some new innovative treatments in this area come through.
Great, thank you. Sophia, I'm going to ask the next question to you, if that's okay. So there's a question about how we have, with this learning and real case scenarios, are we involving people with mental illness or practitioners to support evaluation and implementation?
Do you mean in the development? Sorry, I'm trying to get clarity on.
I think so. I was hoping that you could say a bit more about how we've involved people,
So
if we have
yes,
involved
absolutely.
people and living with the condition and practitioners in the development of the reference case extension.
Yes, so when we developed the reference case extension, we had multiple workshops, the first of which was with healthcare professionals, and we had representative groups representing people living with obesity. And in those discussions, we tried to identify the different elements that impact patients specifically and their health-related quality of life, including mental health. So that was something that was discussed. We had further workshops as well with industry as well as with commissioners. So throughout those, and health economists, so throughout those workshops, we touched upon the different elements that we felt were important to include within the reference case extension, and that's reflected in the content. And as we mentioned earlier, we obviously also had a stakeholder consultation, which gave a wider group of stakeholders the opportunity to comment on the content of our reference case extension.
Great, thanks very much. Dave, the next question I'm going to ask you, and it is whether you can recommend a specific risk prediction tool.
Well, we've got a number of outcomes in the reference case extension, so there's a number of risk tools that could potentially be used. So the first thing, as has already been mentioned, in response to stakeholder feedback, we decided to place less emphasis on risk equations and more emphasis on direct evidence. We heard what you said, and we responded accordingly. But I know some stakeholders would have liked us to have provided some recommended risk tools, um, we found it a bit problematic because, again, as some stakeholders informed us, there's no, there's probably no tool that's recommended that's validated across all 8 of our strata. So we've got different outcomes and different strata. And rather than do a systematic review for all of them, we felt that we would leave it open, but ask um, that manufacturers or modelers um, eh, just justify the risk tool that they've chosen. Um,
Great.
yeah.
Thank you for answering that. Lindsay, the next question is for you. Does the reference case extension restrict innovation?
Well, I really hope not. Innovative approaches is something that we really value and really hope to embrace. Yeah, so we recognise as well that over time, especially if you're modelling in a new area, you might get a greater understanding about what is best practice in models, or you might have more data that gets available as people publish their work. So, of course, we'd like to recognise this and incorporate it where it's appropriate to do so. So I think this being the first reference case extension, we will be looking as well to see how it is implemented when we have our first topic, when that gets selected, and then once that's gone through and once we've used the reference case extension, then we can start to think about how we might update it in the future. Thanks.
Great, thank you. Sophia, a question for you. Do we know what the first topic is to apply the reference case extension?
Thank you, Jack. We haven't identified the first topic yet. However, as mentioned earlier, all topics that are undergoing scoping from May 2026 will be considered for the reference case extension. This will be discussed with manufacturers. This is in terms of technology appraisals and health tech at the scoping stage. We do expect, however, that the models that are undergoing development to consider our reference case extension, as this is based on evidence and best practice. And so any models that substantially deviate from our reference case extension will be queried, or we will wonder, what the precedent is for that. So but it will be something that will be established at scoping stage. So all manufacturers will have that discussed at that early side.
Great, thank you. Dave, I'm going to ask you a question about interactions between risk factors next. Specifically, how should interaction between risk factors be handled? So, in a scenario where one condition increases the risk of another included condition.
Well, I suppose in part uh, we've we've captured that through our subgrouping and through having multiple disease pathways captured in the model, ASCVD, type 2 diabetes, and chronic kidney disease. And yeah, I guess ideally it'd be good to have some CPRD analysis that captures um, a multivariate analysis that captures event rates, adjusting for different comorbidities. Our planned data analysis does that up to a point, but I'll be honest, there's still a long way to go in that regard.
Thank you for that.
But also, I mean, we've tried to make recommendations about controlling about using utilities and costs that control both for different comorbidities and for weight group as well there. With utilities, I'm aware that there's definitely evidence out there for this. For costs, then there may well be usable evidence in the published literature as well.
Great, thank you. So I think one of the questions, and Lindsay, I'm wondering whether you would be able to answer this one, is about whether BMI is the best measure of obesity to use, and what is the evidence for using BMI in preference to other measures such as waist to height ratio.
Yes, we did get a fair few comments about that at consultation, actually. We did spend a lot of time discussing the best measure to link this to. Obviously, in our recent obesity guideline, we did recommend the use of waist to height as a measure for that. I think the reason why we didn't include it in the reference case extension is because at the time and since then as well, it's not that helpful compared to BMI in terms of the data available and the risk tools in predicting the future outcomes. So the risk tools that we were considering at the time and that we were aware of, they were based on BMI. And we couldn't find any that use waist to height. So as a measure in itself for predicting obesity in people, it's obviously very useful, especially on an individual level. But for an economic modelling perspective, we found it a lot more challenging to justify its use, and we thought that if it was to be recommended, it would make it a lot more challenging to be able to develop these type of economic analyses.
Great, thank you. Sophia, question for you. Do reference case extensions also include rare diseases, or could rare diseases, I suppose, be selected for a reference case extension?
So in the case of obesity, we have actually not actively included the rare genetic or syndromic causes of obesity. This is because some of the conditions might be, the pathways treatment pathways might be different. In terms of future reference case extensions, the way we're selecting topics mean that these wouldn't necessarily be selected, but should there be a case for establishing consistent modelling, these could be addressed if there was a strong case for a need for additional work and guidance on how best to model these conditions.
Great, thank you. Then a question for Dave. Regarding health states, can patients transition from type 2 diabetes to the stroke/CKD health states? This person says that they cannot see a transition there in the schematic published.
Absolutely. Yes, I suppose the schematic, it's not a state transition model diagram in its purest form. It's showing three different pathways. But yes, the event rates should be influenced by all three elements of the health state, or all four elements, I should say, by the current CVD status. So yes, your probability of moving to diabetes should be influenced by your CVD state, your CKD state, and your weight group.
Great, thank you. There's another question which is quite long, but Dave, I think it is for you probably to answer. But hopefully you will have been able to see the full question in the chat. I won't read out all of it, but I think the question comes down to, should the treatment effect be incorporated by an additive or a multiplicative effect on baseline?
Sorry, I haven't seen the exact wording, but I suppose it's different about what treatment effect we're talking about. If we're talking about weight, as we may
Yes.
well be, we're talking about weight. Hmm. Well, I mean, I don't think we've specified anything on that in the reference case extension. It is a good question, but I suppose potentially it could be additive or multiplicative. But I suppose if you're applying the same treatment effect across different strata or different subgroups, then multiplicative would definitely be the way to go.
Great, thank you for that. I think we're nearing the end of the questions, and we are also nearing the end of the time set out for this webinar. But I think the final question, and I'm wondering, um, Sophia, this might be one for you, which is that the obesity extension largely seems to codify existing appraisal precedent, where we've already seen evaluations in this condition, whereas the mass extension would likely need to establish new methodological precedent because there isn't the same body of evidence or experience with evaluating technologies for that condition. So, how comfortable is NICE with reference case extensions that play more of that precedent setting role? Or I suppose this person is asking, should they be reserved for areas where methodological consensus already exists from prior appraisals? I'm curious what your view is.
Thank you, Jack. So the MASH project is really coming off the back of some HTA lab work that has been done to look at how treatments can be modeled in that area. So extensive workshops were held to try and understand the best modeling approaches. We feel it's important to set the precedent in this instance because there's a strong pipeline of treatments coming and we'd like to establish consistency early on. But it has been, as the same as the obesity reference case extension, a highly collaborative project, and we'll continue to have stakeholder engagement. So I think we do feel quite comfortable in doing this, but as with the obesity reference case extension, these aren't static documents. We will look and learn from experiences. So from this obesity reference case extension, we will see how people apply it and what justifications are provided, and take those learnings into future reference case extensions and adapt and ensure that it's staying relevant and close to the developments that are happening within the condition area.
I completely agree with that. And I would add as well that I especially when that consensus doesn't yet exist, just because NICE hasn't necessarily evaluated a condition doesn't mean that we cannot or not are not able to identify what best practice is or should be, and provide I think a helpful steer on that, hopefully increasing the predictability of what NICE will consider important in evaluating those conditions. So completely agree with that. I can't see any new questions coming through. So I am going to first start by thanking our speakers for taking us through this exciting work and presenting how we've developed it and how we are implementing it, as well as the contents of the reference case extension. For those of you who want to know more or might have unanswered questions after this webinar, there are a number of different ways in which you can approach us with either further questions or specifically for developers or companies who are thinking about how they can apply the reference case extension. Our NICE advice services can be contacted via the QR code. And there are newsletters that people can subscribe to, as well as more information on our website. So thank you very much for attending, for sending us all of your questions, and have a great rest of your day.